Okay, so we'll move on to the next debate, and we welcome Dr. Waleed Vmix and Dr. Sidney Low, who will be talking on this topic, which I think dilemma which we face every day now in the cath labs is non-culprit lesion in STEMI, to do or not to do. So Dr. Sidney Low is going to be talking in favor of the motion. Dr. Sidney.
Thank you very much. It's very honored to be invited to speak and share in Pakistan Live. Can you hear me okay? Okay, so presumably you can hear me, yes?
Yeah, we can hear you very well. I think we can see your slides as well.
Go on.
Thank you.
Okay. So I think that we're talking about multi-vessel disease during STEMI, and so non-culprit lesions up to 50% of STEMI patients. And the definitions vary in the clinical studies, in observational clinical trials. And we know that actually in the syntax trial, the more complicated you are in a syntax anatomical score, you can see that PCI are actually more likely to be incompletely revascularized. And the meta-analysis of almost 90,000 patients of many studies also demonstrate that PCI is more likely to be under complete revascularization. And this is also demonstrated that the more complex your lesions, if you've got CTOs particularly, or complex bifurcations, the less likely you are to be completely revascularized. But the description is a little bit difficult, and I think that the best way of describing this may be the residual syntax score, what you are left with that are not revascularized. And looking from many different studies that I've seen here, from Genero and also from Sonia Burgess from my own center, have published some of this data, is that if the residual syntax score is above 8, then a significant myocardial ischemia or unrevascularized myocardium leading to adverse cardiac events on long-term follow-up. You can see all-cause death, and particularly myocardial infarction, may be increased. Diabetes also increases the rate of multivessel disease. You can see here in our own cohort, observational study from our center up to 10 years, 12% may have difference in rates in multivessel PCI. And cardiovascular death rates in patient multivessel and STEMIs are higher in diabetic patients. Notice this rate is almost double. And of course, the difference in the rates of cardiac death between diabetics and non-diabetics with multivessel disease and STEMI are evident very early, but actually extends to long-term follow-up, even over a 10-year period. We also found some high-risk populations, such as ladies. So women compared to men with a residual syntax score above 8 had twice the risk of cardiovascular death or MI post-STEMI, and maybe 3 times the risk of cardiovascular death. I'll show you a case. This is a recent case from a couple of years ago. 66-year-old male with inferior STEMI, a smoker. Lots of VT-VF storm, 39 defibrillations, heart block and a temporary wire has been placed. LADs occluded. The culprit is the right coronary artery, and the right coronary artery was stented, and he stabilized very quickly. At the end, tail end of this, you can see that on the top end here, the LED is filling just a little bit. Very hard to see, but it's on the top of the screen there. You can see LED filling. So the right coronary artery was actually collateralizing the LED. He stabilized. 10 days later, returned and had a PCI, which was fairly easy to do. LED was stented successfully. And actually, the function was preserved. Very, very lucky for that. Incomplete trial is a large randomized trial of revascularization of non-culprit vessels versus culprit vessels. The co-primary endpoint of cardiovascular death or new MI was significantly reduced with those having complete revascularization. There's only 1% that needed FFR. These are lesions which are between 50 and 70%, and almost all of these are less than 0.80. But if you had an angiographic lesion of 70%, you're allowed to stent those in a non-culprit sense. And meta-analyses, 3 of them, have demonstrated that cardiovascular death is reduced if you fix non-culprit vessels. Now, the FFR guidance, though, in these populations have not demonstrated cardiovascular death reduction, but there is a reduction in ischemic-driven revascularization. What is the timing? In the complete trial, majority of patients were done with a median of about a day. There's about 4% done within the 35-day period, and 84% completely revascularized within 3 weeks. But after revascularization, which was complete, the residual syntax score was actually 0. Recently, the BioVast study looked at a non-inferiority trial looking at stage STEMI and non-STEMI patients immediately or staged And you can see that actually in this study, there was no difference in all-cause mortality, but myocardial infarction was numerically increased and unplanned revascularization was increased if you were staged. Presumably, either you didn't identify the culprit properly or those other lesions were unstable and needed to be revascularized urgently in the follow-up period between your scheduling for a stage PCI. The only out is really culprit shock with multivessel disease, and you see the primary endpoint of death and renal replacement therapy is increased if you did a non-culprit. However, in this study, CTOs were actually included. They were actually attempted, and 81% were successful. The question is that did this lead to more renal replacement therapy because of CTO PCI in a non-culprit lesion? Mechanical cardiac support was also done in about a third of patients, but notice that there's a disparity a little bit numerically between who got impeller CPs, between culprit and multivessel versus ECMO, as well was actually the other way around, and bleeding was higher in the ECMO patients. We don't need FFRYs to tell us if the non-culprit is actually ischemic, and in this study, when you only have to have an angiographic stenosis of 50%, you were actually doing half the population, and really there was increased event rates with the use of a pressure wire and did not add a lot. So the good news is we don't really need to use FFR unless you really have doubt. I'll show you a case. A 51-year-old man, some years ago, diabetic smoker, anterior STEMI with shock. But he survived very well, and with just the LAD done, you can see circumflex disease, proximal OM, proximal right coronary disease. LAD proximal was stented, the mid-LAD lesion was left, and a heart team discussion, hit a balloon pump. And we actually brought him back a few months later because we needed to understand if the LAD needed to be performed in terms of revascularization. FFR actually was 0.88, and it was felt that revascularization of the LAD was not necessary. It did not go to surgery. The right coronary artery was stented. The circumflex was stented, actually leaving an OM, which is a residual syntax score of approximately 5. But at 7 years follow-up, he's been well, and it did not really require further revascularization. So in terms of the guidelines, this is from the 2021 ACC-AHA guidelines, and you see level 1A in selected stable patients with STEMI and multivessel disease, the PCI, after successful primary PCI, is recommended to reduce the risk of death or myocardial infarction. You may be considered, if you have successful PCI, elective surgery for the rest of the vessels is reasonable in terms of consensus agreement. You may consider just doing a non-culprit vessel at the time of prime PCI if the patients are very low complexity in a non-culprit vessel, but you shouldn't really do it in the terms of the data, in terms of cardiogenic shock, from what I showed you from culprit shock. So in their scenario, STEMI, and if you're not in shock, if you are in shock, sorry, you shouldn't really do the non-culprits. If you're not, as low complexity, you may do it at the same sitting. You can defer the non-culprit vessels, but if it's not a large myocardial territory, you may just treat medically after a heart team discussion. If it is a large, more complex and multi-vessel territory and you're complicated, you can decide whether or not you would do bypass of non-culprits or stage PCI. But if it's fairly simple, then stage PCI is very reasonable. So in conclusion, revascularization of non-culprit lesions are very worthwhile. We think it reduces cardiovascular death, MI, and possibly ischemia-driven revascularization. Simple lesions can be done immediately in the same procedure. There's data for that. And CABG may still be reasonable for complicated non-culprit anatomy post-successful primary PCI. FFR may not be necessary at all in non-culprit lesions unless there is doubt about its significance, and shock remains complicated, and non-culprit lesions usually are staged in this scenario. So thank you very much for your attention.
Thank you very much, Dr. Loh, and thank you for finishing in time. Now it's time for Dr. Waleed Kayani to be speaking against the motion, and also has the task to finish within time, because that's what Dr. Loh did. So, Dr. Kayani. Yeah, we can see you, and we can see your slides.
Can you all hear me?
Yes.
Okay. So, Dr. Loh, thank you for the wonderful talk, and to the committee for having me over from Houston, Texas. I think you pretty much answered a big part of my talk by saying that some of these lesions can safely be staged. What I'm going to be talking about is that not these lesions, and most of them, in fact, don't need to be done in the same setting in the middle of the night. I have no relevant disclosures. Just to quickly go over the background, about half of patients that present with ST elevation MIs have residual significant disease in the other vessels. We know that residual disease in the other vessels is associated with less ST segment resolution after primary PCI, even if it's successful, and also leads to downstream hard events like increased mortality at 1 year. Whereas the studies over the last decade have clearly shown that taking care of these significant non-culprit stenosis is important, what remains questioned to an extent, including the debate today, is when exactly to do it. Do we need to do it in the middle of the night when we're doing the index procedure on a totally occluded vessel? Do we need to do it before discharge? Or do we need to bring the patient back in a staged outpatient fashion? Dr. Lowe very nicely went over the complete trial results, which has set the center stage and almost become the cornerstone of our data for this particular question. 4,000 patients clearly showed that if complete revascularization is done versus just culprit-only stenosis over the long term, the patients who undergo complete revascularization do well. I'm going to argue that these curves separate actually later. If you look at the Kaplan-Meier curves, they start separating at 2 to 3 months out. So what's the point in doing this procedure in the same setting, in the middle of the night or the next day? Why not wait a little bit? Indeed, complete trial investigators asked this very question from the subset analysis of 2,100 patients from the complete trial that underwent complete revascularization. They compared outcomes in patients who underwent non-culprit PCI during the index procedure or the next day versus staged outpatient procedure, which was the 1/3 of the patients in about 15 to 18 days. Overall, both the cohorts were well matched, and what the investigators saw in this subgroup analysis of complete trial that was published in JACC in 2009, that really for the first 45 days, there was no significant difference between complete revascularization or culprit-only revascularization. So really after 45 days is where the Kaplan-Meier curve separated to favor complete revascularization. What they also showed here, shown on the left, is that if the arteries were stented, if the non-culprits were stented during the index hospitalization or after discharge, within the 30-day period, there was a significant benefit favoring complete revascularization compared to culprit-only. In terms of subgroup analysis, you can see in terms of death, myocardial infarction or cardiovascular death, or the composite endpoints, there was no significant difference favoring either index procedure or stage stenting of non-culprit stenosis. And the authors rightfully so concluded that among ST elevation MI patients with multivessel disease, the benefit of complete revascularization over culprit-only PCI was consistent, irrespective of the investigated determined timing of non-culprit intervention. The benefit of complete revascularization on hard outcomes emerged mainly over the long term. I'm going to go over 2 meta-analyses to build my point. This is again an important meta-analysis published last year in Heart. 7,500 patients, 11 randomized controlled trials. On the top panel here is shown complete revascularization done during index hospitalization compared to culprit-only PCI. As you can see, significant benefit favoring complete revascularization. At the bottom panel here, you can see complete revascularization done in a staged fashion compared to culprit lesion-only PCI, again showing a significant difference on major adverse cardiovascular events. Median time in the first group was 1.78 days. Median time in the second group was 18 days, where the patients were brought back in a staged fashion. Again, regression analysis, same thing. As long as complete revascularization is done within a timely fashion, the time to PCI is not significantly associated with adverse events. Important meta-analysis again, whereby same question was looked at in 12 randomized controlled trials. The investigations again conclude that evidence, that there is no significant evidence to favor either inpatient or staged comparing each other. Like it could be done either in the same setting or the patient could be brought back in a staged fashion to completely revascularized, and the same benefit would be seen. So to conclude my point, in the patients that come to us with ST elevation MI, of course, we follow the guidelines in terms of revascularizing the culprit lesion, but what do we do with the non-culprit lesion? My suggestion is in non-severe stenosis, they can be left alone. In severe stenosis, for the majority of patients, I suggest a staged PCI, whereas only in a small subgroup where the stenosis on the other side is unstable, where you see hazy thrombus or something that we feel is not going to be able to be staged, or if there's persistent ischemia after culprit lesion PCI, should you proceed to stent the other side. So, just to conclude my point, I would say culprit-only PCI during index procedure should be the default approach. Significant non-culprit stenosis should be managed in a staged fashion, either before discharge or the patient be brought back early on as an outpatient. Hopefully, over the last few minutes, I've been able to convince that there's similar benefits in terms of hard endpoints like death, cardiovascular mortality, and myocardial infarction, whether the procedure is done during the same setting or brought back. We would also agree that it decreases contrast load. It avoids the risk of over or underestimation of non-culprit lesions. You can also establish patient compliance in case that's an issue that we consider. And the last but not the least, it reduces team fatigue for after-hour cases, which many of us do as ST elevation MIs. Thank you.
Thank you very much, Dr. Kiani. Dr. Low, do you have any points to add here from your side?
Yes, look, I think we have lots of agreement. I think the complete revascularization is indicated. I think it should be aimed for if it's a large territory. But I think that there also, the timing is really dependent on where you work and how things are done. Logistically speaking, I think that if there's very, very simple lesions, many people would do the non-culprit very quickly, maybe at the same sitting. But obviously, if you had a lot of trouble doing a very clotty thrombotic right coronary artery, you may stage that LAD before discharge, and that's a common practice where we are at. I think it depends on how you reimburse and how you're funding your system. You want to avoid too many trips to the cath lab if you can, but then again, there's a lot of safety involved, and I think we will still talk about left main LAD kind of lesions. Maybe surgery might be indicated if they're diabetic, and so we may even send them for surgery revas in a stage sense and discuss that in the heart team. So I have, lots of agreement there, and I think that the trial complete wasn't actually meant to study the timing. It was physician determined, so we don't know exactly. But in BioVasc, I think there is a risk if you wait too long, I guess.
Thank you. Dr. Kiani, do you have anything to add here?
Totally agree with Dr. Low. I think the question is how long is too long. I do feel, as long as it's within, and the data would support that, as long as it's done within 2 to 3 weeks, unless the other lesion is unstable, you would derive a similar benefit on hard outcomes.
Okay, thank you, Dr. Low and Dr. Kiani. I asked Dr. Merwat Sang to say concluding remarks here and how things are practiced in her setting.
Well, thank you both, Waleed and Sydney, for these excellent presentations. You most certainly had compelling arguments, but they were also very complementary, actually. I think there's agreement that complete revascularization is critical. Residual syntax score certainly increases mortality in women and in the population at large. The issue is identifying the non-culprit vessel and its significance. Flower MI or physiology suggests that it's not the best of guides, although that particular trial, could have been redesigned and redone with a wide confidence interval. I would interpret the results with a pinch of salt. We do know that the OCT sub-study of the complete trial suggests that that may be a means to evaluate the non-culprit vessel. But again, it was just a pilot and it really can't draw any conclusions from it. But then the other thing about timing, when to do it. There are a lot of logistics. When you're working in a tertiary center and your patients are coming from afar, when there's insurance, payments, etc. But I do echo what Sydney said about the BioVasc trial that was just presented in ACC 2023. Although it was non-inferior, delayed versus the same hospitalization or same procedure, there was a signal to higher myocardial infarctions and readmissions. So perhaps we need to be identifying these culprit vessels and whether they're vulnerable or not sooner than later in the index hospitalization, and then consider who are the patients whom we can defer versus those that we can do right away. So I think that's still the million-dollar question. So again, thank you very much, both of you, for this really fantastic talk.
Thank you, Marath. So we are going to hold the debate for a while and go to a live case from PIC. So we can connect to the live case, please.